Good afternoon, everybody, and thanks for joining. I think we'll get started. My name is Jonathan Sussman, and I'm a radiation oncologist and health services researcher at McMaster University. It's my honor to moderate today in these unusual times, and I hope everybody's well. It's nice to see some familiar names and faces on the tiles, and I hope everybody's doing well, and we will sort of connect with you. A nice way to connect with each other. Nice to see people really from across the country on the call. Good morning to those individuals who are on the West Coast. And today I have the privilege actually of introducing Dr. Courtney Koshy, who is a fellow in our program in medical oncology here at McMaster University, who got involved in a project starting a few years ago that really began with a bit of a conversation that she'll perhaps tell us a little bit about. As you can see, Courtney's got a PhD and actually started her career as a basic scientist, and then saw the light and decided that she wanted to be hands-on, and completed medical school internal medicine training, and then went on to medical oncology and is actually going to be doing a fellowship as well. And I met her early on in her training when we started to have some conversations about some of her observations in survivorship, and she started reading some of the materials. And in fact, many people on this webinar had actually written around survivorship and some of the challenges that we have specifically around models of care. So that led to the project that Courtney's going to describe to us today about trying to drill down a little bit more on what the oncologists' perspective are around survivorship care, and in particular transition, recognizing that we're currently in the middle of a once-in-a-generation pandemic where the idea of models of care has been blown wide open. I think it's still important to remember that in context, this is still about individuals trying to figure out what the best way to organize care is to provide the best care for the highest number of individuals, it's the highest quality. So we'll go into the presentation momentarily, and then there'll be a little bit of a discussion with some Q&A that I think you can be unmuted or type in, and I can read off of the chat. And I'd also like to remind individuals that this session is being recorded. So I'd like to hand it over now to Dr. Koshy, who will take us through some of her work and her thoughts around the attitudes and beliefs of oncologists regarding the transitioning and sharing of survivorship care.
Great. Thank you so much for the kind introduction, and thank you as well for the opportunity to present at these rounds. As Jonathan said, I'm excited to talk to you about this project that I've been involved with over the last couple of years. So why don't we get right to it? There. So I'm only briefly going to touch upon the unique stage of cancer survivorship. I know this group doesn't need a primer on that. I'll review a little bit about the attitudes and beliefs of patients and primary care physicians on survivorship care as it's been reported in the literature, just to help sort of set up the question that we were asking in this project. I'll talk about the results of a survey that we conducted at our regional cancer center regarding oncologists' beliefs on transitioning and sharing survivorship care. And then finally, we can discuss some potential next steps towards improving survivorship care. So we'll start with a little bit of background. We know that with improvements in screening and treatment, as well as just an increasing population, we have an increasing number of cancer survivors every year. And so, for example, some statistics tell us that new cases in Canada, new cancer cases are expected to increase by about 40% from 2015, in which there were 2.1 million cases, through to 2030. And that survival for all cancers combined has risen from 55% in 1992 to 1994 to 63% in 2012 to 2014. And so we have a large population, which is wonderful, of these patients and people that have survived their cancer. Cancer survivors, as you all know, have unique needs, and these include but aren't limited to monitoring for recurrence, managing late and long-term effects of treatment, other psychosocial considerations, and notably comorbidity management. Interestingly, in a survey of patients in the survivorship stage, many survivors think that their oncologists are their main provider for all of their care, as opposed to just their oncology-related care. And in that same vein, when they ask oncologists the same question, oncologists believe, quite understandably, that they're responsible for addressing cancer needs, but not other comorbidities that are unrelated to the cancer. And so there is a discrepancy there. And unfortunately, this sometimes leads to a lack of care for these comorbidities in survivorship patients. For example, a study that looked at breast cancer survivors found that they were more likely to die from modifiable conditions versus their age and comorbidity matched cohorts that did not have breast cancer. And these patients were also less likely to receive chronic care for these comorbidities. So we know that there's room for improvement there. With increasingly limited resources, we need to identify opportunities to provide optimal high quality survivorship care. And to this end, Choosing Wisely Canada has come up with a statement that says that we shouldn't deliver care, for example, follow-up care, in a high cost setting, such as inpatient care at a cancer center, that could be delivered just as effectively in a lower cost setting, such as a primary care setting. And so that got me interested in going down this path of looking at how we deliver survivorship care. When we look at how primary care physicians are already involved in survivorship, several studies have reported that patients experience increased quality of life when their family doctor is involved. They have better physical and emotional functioning. And the patients also reported having a greater empowerment over their own healthcare. Importantly, there were not found to be any differences in recurrence-related events or time to detection of recurrence when patients were followed by family doctors or primary care physicians versus oncologist-led care. And a couple of the papers thought that this was likely because when a patient is going to present with a recurrence, often it's because they're having symptoms. And so whether they present to their family doctor or their specialist, the timing of that doesn't change. And so that's encouraging as well. Patients generally have confidence in their family doctors to provide survivorship care. And when asked about survivorship care plans, which we'll talk a little bit about later on, they support the use of those to help guide their survivorship care. When we look at studies from primary care physicians and what their perspectives are, many are actually interested in sharing or taking on transition survivorship care of patients that they already see in their practice. But with a few caveats. They want to make sure that they have easy access to repatriation to the cancer center. If a recurrence is found, they would like to have easier access to oncologists if they do have specific questions. And they do very much favor survivorship care plans or some kind of communication tool so that they have some guidance for what to look for down the road for these patients and how to manage any issues that come up. So despite knowing that patients are confident in PCPs, the primary care physicians themselves are confident and willing to take on patients in the survivorship stage of their cancer, and that outcomes are better for patients, patients are still not being transitioned. And so we wanted to look at why that is. Relatively less is known about the perspective of oncologists as a key stakeholder in this group. When you look at the literature, generally surveys of oncologists say that there's a lack of confidence in primary care physicians to provide management for late and long-term effects of treatment, as well as in detecting recurrence for patients. And then previous studies, when we look in within Canada, they are limited by disease type. So they either look at only, for example, breast cancer or colon cancer. They're limited by oncologist type. So I've seen a few studies that were strictly from a surgical perspective or method. So they were more freestyle interviews and didn't have questions that we could use to sort of quantify responses. And they were also far back or remote in time. So sometime in the last perhaps 10 years, we haven't had a large update on what oncologists in Canada might be thinking around this question. So we were hoping to start trying to chip away or fill in that gap a little bit. And we conducted a prospective survey of oncologists within a regional cancer program to obtain a better understanding of perceptions and practices of sharing and transitioning survivorship care. So I'll just tell you a little bit about our survey design. I conducted a systematic review using Ovid Medline in process and other non-index citations as listed there. We used some keywords, concepts, and phrases that were searched individually, and we did this with the help of our Cancer Center librarian. We looked at the results, and we wanted to ensure that the search yielded key previously known papers from the respective categories, which they did. So once we confirmed that, a complete search was conducted by combining the predetermined individual search parameters, and that yielded 292 papers. We screened for relevance and came down to 75 papers. And then in going through those 75 papers, that led us to find a few other papers that were quite relevant to answering this question, as well as some other documents from Cancer Care Ontario, as that's the province that we are in, or our regional cancer center. And ultimately, we had 107 papers, guidelines, and documents that informed our literature review. 63 papers were found to be review articles or original research on survivorship care plans, the feasibility and outcomes of shared or transition survivorship care. They couldn't be obtained with our institutional access or were not translated into English. So that left us with 44 original research papers that specifically queried attitudes and beliefs regarding survivorship care. And some papers looked strictly at patient or primary care physician or oncologist, and some included information from both. So ultimately, 15 papers had patient perspectives, 35 papers had primary care physician perspectives, and 20 papers had oncologist perspectives. In looking through the literature, none of them really revealed a set of questions that we wanted to use to address our study-specific query. So we decided to create our own questionnaire according to this 14-item theoretical domains framework in order to increase the applicability of our questions and the success. So the idea that we would actually get the information that we were hoping to get from the questions that we were asking. We used expert opinion in addition to the questions that we found from the literature review in order to optimize our content validity. And then we did pilot test our survey for readability, clarity, and content. We had one non-physician professional, one non-oncologist physician, and 3 practicing oncologists review the survey before we were ready to have it sent out. The final survey had 22 questions. They included multiple choice questions, Likert scales, which ranged from 1 to 5, as well as opportunities for free text responses. In the case that the respondents had come up with topics other than what we had mentioned in our survey. We split the survey into 3 categories. We had a demographics section, a current practice section, and a section that queried respondents on barriers and facilitators to sharing transitioning survivorship care. Our survey link was sent out by email, and it remained open for 4 weeks before we closed it and collected the data. We performed descriptive statistics on our demographic variables, and with the Likert scales, we grouped 1 and 2 together as disagree, 1 being strongly disagree and 2 being just disagree. Then number 3 remained neither agree nor disagree, and we grouped 4 and 5, which were agree and strongly agree, into 1 category as well when we were looking at the results. With respect to our regional cancer center, all practicing medical, radiation, hematologic, and general practitioner oncologists at the Juravinski Cancer Center were sent the link. Our cancer center sees around 23,000 patients annually, 7,500 of which are new each year. And we did have ethics approval from our local research ethics board to do this survey. For the purposes of our survey, we define survivorship as a stage of a patient's experience with cancer where active therapy is complete and there's no evidence of active disease. Focus shifts to monitoring for recurrence, managing late and long-term effects of treatment, and general psychosocial health promotion. So let's dig into some of those results. We had a 63% response rate, which is quite good, and that was a total of 39 responses. And we had good representation across type of oncologist. So you can see from this table here, we have roughly 43% and 38% split between type of salary for the respondents for the survey. And 66.7%, or about 2/3, had been in practice for more than 10 years. And the largest group of respondents were our radiation oncology and medical oncology physicians. A variety of disease sites were also represented in our respondents. Most people practice multiple disease sites, so you'll notice that the percentages do not add up to 100. And so the greatest proportion were breast, colon, and other gastrointestinal, or other malignancies that weren't captured in this list. And then obviously smaller numbers of some of the other disease sites. In terms of current self-reported practices, we asked respondents to think about the rates at which they transition survivors out of their practice. So 15% actually reported that they don't transition any patients. They keep all of their patients. 41% of respondents reported that they transition up to 1/5 of their patients. 20% reported that they actually transition more than 60% of their patients. And then in total, 72% of respondents said that at the time point in which they start to consider transitioning patients, it's roughly around that 5 years after having specialist care before they feel comfortable transitioning to a primary care physician. When we asked respondents to look at their current survivor caseload, 92% indicated that at least some of those patients that they were still seeing could reasonably be transitioned to primary care physicians. So 24% felt that somewhere between 21 and 40% could be transitioned. And actually 43% felt that more than 40% of their current survivor caseload could actually reasonably be transitioned to a primary care physician at this time. When respondents indicated that they did not currently transition any of their patients, 67% actually stated that about 60% of their patients could reasonably be transitioned. So that represents a large group of their population, survivorship population, that they're still seeing that could be transitioned. But 2 respondents remained confident that they would not want to transition any of their patients. After looking at how they reported their current practices, we asked oncologists to think about who is best able to provide the indicated aspects of survivorship care. So when we look at treatment of patients' other comorbidities, not surprisingly, the majority of people felt that the primary care physician is the best person to treat those things, with a small proportion feeling that either could, and an even smaller proportion feeling that the oncology team may actually be best for that. In terms of providing psychosocial support, almost equal groups felt that the PCP was best able to do that, as well as either the PCP or the oncology team. When we look at following long-term effects of treatment and surveillance for late effects of treatment, a significant group of respondents felt that the oncology team was actually the best team to lead that care or provide that care, whereas almost half still felt that either the PCP or the oncology team could do that. In terms of performing surveillance for recurrence of the malignancy for which the patient was being seen at the cancer center by the oncologist, half felt that the oncology team was best able to perform that surveillance, but 38% still felt that the PCP would be capable of doing that. Would be capable of doing that, as well as the oncology team. And then finally, in terms of screening for new primary malignancies, 41 of respondents felt that the PCP was best poised to do that, and they do that anyways in their practice. They are screening champions. And 38% felt that either the PCP or the medical oncologist could be responsible for screening new primary malignancies unrelated to the one that they currently had.
Yes.
Okay,
yep.
Perfect. Thank you. So we'll just start at the beginning of this figure again, just for the purposes of the recording. So after we looked at or asked oncologists to comment on how they're currently transitioning patients, we asked them to state the level with which they agreed or disagreed with whether the indicated outcomes below would change their practice if they in fact transitioned the patients that they said that they potentially could, but hadn't yet. So if we look here, we can see 67% of respondents felt that this would in fact free more time in their practice to see new patients versus 19% that didn't. 76% felt it would free time in their practice to spend on current patients versus 13% that didn't. 49% felt that it would not actually take extra time to assess patients for possible shared or transferred care. However, 30% did think that this may take more time out of their practice. 63% felt that it would free time in their practice to spend on other administrative, research, or teaching responsibilities versus 16% that didn't. And 51% felt that, or did not feel, sorry, that it would take more time to co-manage a patient with the primary care physician versus 13% who felt that it would take more time to do that. So after asking them to theorize on whether their practice would change if they were able to transition these patients, we asked them to have a look at whether they perceived certain administrative, patient, personal, or disease factors as barriers or facilitators to transitioning survivorship care to primary care physicians. So first, if we look at administrative factors, the strongest barriers, which you'll see on the left here in blue and purple, to transitioning care were that the patient being in a clinical trial, which is understandable, the physician being concerned that there would be risk of gaps in patient care, loss of patient outcome data, and lack of clear guidelines in the disease site to help inform that transition. And you can see on the side here the percentage of respondents that felt that these were neither barriers nor facilitators. So despite these being stronger barriers versus facilitators, there was still at least half of the respondents that felt that they were neither barriers nor facilitators. If we look at the strongest facilitators, having a survivorship care plan to send to the family physician was considered to be a facilitator. And having an obvious repatriation route if there's an oncology-related problem that the primary care physician could easily use was also a facilitator. If we look at patient factors, not surprisingly, these strong barriers include that the patient does not want to transition to their primary care physician, that they're anxious about it, that they're having ongoing side effects from their cancer therapy, which I'm sure as physicians, we can all appreciate some ownership that we might take over patients having those effects from treatment we prescribe. Patient using services at your cancer center, such as psychosocial support, social work support, or dietitian support. The patient being on ongoing adjuvant therapy despite their primary therapy being completed. Those were the strongest barriers, though you can still see that patient using other services and ongoing therapy for a large proportion of respondents were neither a barrier nor facilitator. And then the 2 points that were facilitators in this category were the patient having access to your practice location. If that was difficult, then that was a facilitator to perhaps bring them back to their family physician. And the patient having more multiple comorbidities was also a facilitator to having them see their family physician versus these patients who felt that they were neither a barrier nor facilitator. If we look at the next category of personal factors, not surprisingly in Canada, 94.4% of people felt that it was neither a barrier nor facilitator that there could be a loss of remuneration for providing patient care. And only a small proportion had indicated that perhaps this might be a barrier. Other stronger barriers in this category included the idea that as oncologists, we did not feel that PCPs may be able to deal with the effects of treatment, or that they could deal with surveillance for recurrence or monitoring for late effects of treatment. And the oncologists that responded to the survey perceived that PCPs may not actually be willing to provide survivorship care for their patient population. Somewhat of a barrier to some of the respondents, about 1/3 of them indicated that they would have fewer longitudinal relationships with their patients and that they would miss that. And so that would be a barrier to transitioning survivorship care. And then a stronger facilitator was that the primary care physician was perceived to be able to deal with psychosocial aspects of care for their patients very well. And actually, almost 2/3 of patients felt that you would, it was neither a barrier nor facilitator that you might see fewer well patients in your clinic. We had included this as there had been a couple papers in the literature which stated that some physicians felt that if they transitioned all of their well patients to primary care physicians, they would only have patients that were struggling, and that might be emotionally difficult to have that as your practice long-term. And then finally, if we look at disease factors as either barriers or facilitators, if the patient had a high likelihood of recurrence, it's very understandable that this was considered to be a strong barrier to transitioning care. if they had long-term sequelae of the treatment for cancer or of the cancer itself. Those were also barriers. And the strongest facilitator, quite understandably, was that if there was a low likelihood of recurrence, most people, almost 80%, felt that this was a facilitator to transitioning to survivorship care. So that brings us to the end of the results, and maybe we can dig into a little bit more of discussion and have a little bit of time left at the end to discuss amongst ourselves. But essentially, we know that we need to provide a new approach for optimal survivorship care, and this is acknowledged internationally in jurisdictions more similar to ourselves, like the UK and Australia, as well as in the United States, where the healthcare system is a bit more different. In Canada, it's acknowledged that there are widely different patterns of specialist and primary care physician visits in the survivorship stage. There was a paper published in 2017 that looked specifically at breast cancer patients, and they found that 33% of breast cancer survivors were followed solely by their primary care physician in British Columbia, and that in the 3 other provinces they looked at, it ranged from 5% in Ontario to 16% in Nova Scotia, and the other province was Manitoba, which fit somewhere in the middle there. And the authors felt that this was likely due to differences in policies and initiatives and varieties of resources and infrastructure to support the transition to primary care physician-led care. And in fact, interestingly, BC Cancer has partnered with a family practice oncology network to offer cancer care outreach, a program on education to primary care physicians and to share best practices throughout the cancer care continuum, but including survivorship care. And so they thought that perhaps this may explain why a large proportion of survivors are being seen solely by primary care physicians in British Columbia. When we look at Ontario, which is where our regional cancer center is located, a survivorship program at Cancer Care Ontario was identified or had identified a wide variety of follow-up care practices for breast cancer survivors across the 14 regional cancer centers that we have. And so what Cancer Care Ontario did was they provided funding for these centers to develop new models of care, and the types of models that were developed included transitioning to PCPs, discharging to a transitional clinic first before being transitioned to a primary care physician, as well as shared care models. And some common themes in these models that these 14 regional centers came up with were providing survivorship care plans, patient education materials as well, and a clear repatriation path to the cancer center. And so Cancer Care Ontario has planned follow-up to assess the sustainability and ongoing implementation of these models. So that will be interesting to see in the future. So why is transition to care not occurring at higher rates if we know that there are better patient outcomes, that there's no concern for missing recurrences, and if patients and family physicians are both confident in PCPs to deliver this care, and PCPs are willing. Our survey sort of had 5 key barriers that we pulled out from the data. The administrative factors such as patient participation in a clinical trial and risk and gaps of patient care, loss of patient outcome data, and lack of existing guidelines for disease sites was a key barrier. Perception that PCPs are not willing or able to provide this care was a barrier as well. Patient factors such as listed there were important barriers, and a disease with a high likelihood of recurrence or long-term sequelae from the cancer or its treatment were key barriers that we found. So despite those barriers, respondents to our survey felt that some proportion of their current practice could reasonably be transitioned. And so there's a discrepancy between what oncologists perceive PCPs are willing to take on and what PCPs feel that they are able to take on. And so we wonder whether there's an opportunity here for some educational intervention to let oncologists know that, PCPs, based on surveys that have been conducted, are willing and able to take this on with a little bit of support, and that patients actually feel that this would be a good thing as well, and whether that would facilitate transitioning care. Interestingly, in the same region where we conducted our survey on oncologists, a survey of primary care physicians was done, and it did support the fact that primary care physicians in this same region are willing and able to take on more survivorship care. So perhaps an opportunity for an educational intervention. We also pulled out some key facilitators to transitioning care, creation of a communication tool, such as a survivorship care plan to support primary care physicians is one of the biggest ones. An easy avenue for repatriation to the oncologist, primary care physician management of psychosocial aspects of survivorship care was a facilitator. Patients that had multiple comorbidities was also a facilitator, and a low likelihood of malignancy recurrence. And a lot of these facilitators agree with what's been published in the literature before. So just a short word on survivorship care plans. Recent data suggests that they don't improve patient-related outcomes as anticipated. However, they still remain a widely accepted communication tool to support primary care physicians in delivering survivorship care. And the nice thing about survivorship care plans is they actually appear, if we include the right things in them, to address some of the barriers and facilitators that we identified in our survey, such as clarifying roles for the specialist and the primary care physician, and this could avoid gaps in care. It can provide recommendations so the primary care physician feels supported in providing survivorship care, and it can also help to outline a key repatriation pathway to the cancer center when there are concerns. So survivorship care plans represent another area for intervention. Providers identified that more of their current population could be transitioned than they are currently transitioning. And so what that suggests is that we may need a process to more readily identify patients whose clinical course could be supported by a shared or transition survivorship approach. Because it seems that on sitting down and thinking about it, they actually are identifying patients that could be transitioned, but for whatever reason, they aren't at the time. In terms of some strengths and limitations to discuss about our work, some limitations include the self-reported nature of the survey results. We had relatively small numbers because we looked at just our regional cancer center, and so that prevented some subgroup analyses based on demographics. We would have liked to try stratified based on those features, but we couldn't. And so we may have missed differences based on provider characteristics. We didn't identify any novel facilitators or barriers in the survey in the free text boxes that we had. And so this could potentially be a limitation to suggest that the respondents didn't feel that they needed to think about other barriers or facilitators that might be there. And these are just results from a single center. And so the question is whether this is representative of other regional centers or just what we see in our area. In terms of strengths, we did compose our survey based on a literature review and expert opinion to ensure inclusion of important theoretical constructs. On the flip side, what could have been viewed as a limitation can also be viewed as a strength. Our survey could potentially have been fairly comprehensive because no novel perspectives emerged from our open text comments. We had a very good response rate, 63%, from the emails that were sent out asking people to participate in the survey. And we did have a broad sample of oncologists and a variety of disease sites represented in the survey as well. So briefly, just to wrap up, oncologists have identified that more of their current practice could be reasonably transitioned to primary care physicians for survivorship care within our region. And we know that oncologist perceptions are therefore integral into developing optimal survivorship care guidelines to facilitate transitioning care, but that this needs to be done with primary care physicians and other healthcare providers. At this time, or at the time that we conducted the survey, the compelling facilitators to non-specialist led care or primary care physician involvement appeared to be outweighed by the barriers because transition was simply not happening. Some of the interventions we identified included educational opportunities to let oncologists know that primary care physicians are willing and able, and perhaps to give them some of the data to support that, to develop an easy to use survivorship care plan for specialists to send to primary care physicians, and to perhaps create a more systematic process to identify patients suitable for transitioning survivorship care so that they can be flagged to the specialist and the specialist can then decide. In terms of future directions, we have demonstrated that our survey is feasible and it would support a larger scale survey of other oncologists, so perhaps expanding through the other regional centers in our province and consideration for including community centers. And this will help to expand the generalizability of our study findings. And then really, there's the potential to address the identified interventions that we talked about that may increase transitioning survivorship care, but we would only pursue that, if our results were perhaps more generalizable. And just a reminder that ultimately the goal is to personalize the model of follow-up survivorship care based on a set of comprehensively developed and evidence-informed criteria, so that it can be applied across broad populations of cancer survivors with a minimum standard of survivorship care plans to inform that transition. And so with that, I would just like to thank you for giving me this opportunity and for tuning back in after that alarming interruption. And I would be happy to facilitate discussion and take questions.